Hey everyone.
Hi, everyone.
Thank you all for jumping on. We'll start in just a minute as people are still filtering in here. Right. Okay. Welcome. Thank you all for coming on today. As a brief introduction, I'm Kelsey. I'm the program manager for MapNet. This is our monthly community didactic call series. Today we're talking about a topic that is relevant to a lot of the work that folks are doing. The kind of a tricky gray area between childhood bipolar disorder, ADHD, and psychosis. And we have an expert in that area that we're really glad to have talking to us today, Dr. Janet Wozniak. So I will hand it off to Dr. Keshvan to do the introduction, and then we can get started.
Yeah, thank you, Kelsey, and good morning, everyone. So it's my great pleasure indeed to introduce our today's speaker, Dr. Janet Wozniak, who is Director of the Pediatric Bipolar Service and also Associate Professor of Psychiatry and Director of the Child and Adolescent Psychiatry Outpatient Department Service at the Mass General Hospital. As Kelsey said, the topic of bipolar disorder as it begins in childhood and adolescence is of great importance to what we do in the early psychosis program, the MapNet across the state. Quite often it's a diagnostic challenge between bipolar disorder and other psychotic disorders. It's also a management challenge. And we have, what who might be considered a national or international leader in this field, Dr. Wozniak. I'll briefly say a little bit about her. She graduated from Harvard College, magna cum laude, and then went on to become a child psychiatrist with a focus on childhood bipolar disorder and ADHD as it interfaces between those disorders. She has published widely, including what might be the most ever cited paper on childhood trauma in the journal Childhood and Adolescent Psychiatry. She has published in various related areas, including psychopharmacology, the use of N-acetylcysteine, and so forth. So she is the go-to person for understanding childhood bipolar disorder as it interfaces with ADHD. So without much further ado, Janet, the floor is yours.
Thank you. Thank you for that nice introduction, and it's nice to meet everybody. I was have a presentation over the next 45 to 60 minutes that I can just keep talking. But I understand that if you put any questions into the chat, that Kelsey will monitor that and interrupt me if there's something that might be relevant for me to detour to make clear. Okay. All right. So I wanted to make sure that the talk is relevant to everybody, and I think it seems clear that in seeing individuals with or first episode psychosis, early onset psychosis, you're probably generally seeing individuals who are in their teen years or later teen years. When I first started doing work in pediatric bipolar disorder, early onset was considered age 17, I think, or something to that effect. And I remember being in some lecture where I heard that I must have been the head of the NIMH talking at the time, saying, if only we could catch some of these people much earlier in their childhood or adolescence. And I like, yes, I've got them. We've got them. We see them. So a lot of times onset is linked to the most severe moment or linked to hospitalization, whereas there actually may have been onset of symptoms much earlier. And when I first started to do this work, people always ask this question, are these kids, do they grow up to have bipolar disorder? Are they the ones we see in our clinic? And so one of my colleagues did this kind of never thought of before idea to ask all of the adults in this bipolar program. They called it the STEP Bipolar Program. It was a program devised to do different studies, especially treatment studies, asking in detail, when did their disorder actually begin? And it was interesting to see that the majority of them reported pediatric onset of their disorder, and about a third of them under the age of 13. So I kind of think of it roughly as a third, a third, a third, a third prepubertal, a third in their adolescent years, and then a third in the adult years. And you might even argue that early adolescent is a 13, 14 is kind of a particularly unusual, quite early age as well. So the people you're seeing as adults probably have had symptoms prior, which will inform their disorder and maybe even lead to some treatment resistance if they hadn't been treated appropriately early on. Individuals you see will have children who start to have this disorder. And I think there's a number of reasons why it would be helpful for everybody to be aware of it. So I hope that that does help everybody who's seeing these folks. The earlier onset individuals in the adult clinic all had much more problems, more comorbidities with anxiety and substance use, more recurrences, which you might kind of construe as a kind of a chronicity rather than kind of long periods of euthymia, and greater suicide attempts, greater violence. So this is a really difficult group to treat.
And
So it's one
actually, we have a question in the chat saying, I'd love to know what specific symptoms people reported as having onset, specifically in those early ages.
Well, you know what? I'm not sure I can speak to Dr. Perlis's study specifically, but I do have a slide to show you about symptoms and how the kids present when we see them as kids. So maybe you've already been sold. Can children really have bipolar disorder? That is a question I've been getting for a long, long time. And even among my colleagues who work with bipolar disorder, there's a skepticism that it could occur at such an early age, like age 8, for example, or 10 or even earlier. Why that is kind of a strange thing. It's like people need a paradigm shift. They kind of get stuck in an idea that the age of onset is later adolescence or something to the effect. I mean, we've been diagnosing depression in kids for a long, long time. Why wouldn't it stand to reason that they might also have symptoms of mania early in life? In my clinic, it's 100% practically of who I see are kids who have bipolar disorder. But we do have some epidemiologic type data. And more or less, even from the very beginning, we speculated that it might affect 1 to 2 or 3% of children and adolescents. And indeed, that's what the studies show. The studies show that it's similar internationally as well. There's overlapping symptoms with mania and ADHD, which it turns out to be quite relevant in child and adolescent psychiatry, but it's certainly not the case that these are a direct overlap. ADHD is a much more common problem. Probably 10% of the population, child and adolescent, has ADHD. It's our bread and butter in our clinic. So these papers that one of them quite early on, and then a replication study, this is the first time that we started to describe the bipolar disorder that we were seeing in our clinic patients. We had the, I guess, luck or useful data that because you were using our clinic sample as a comparator to a research sample that was being ascertained for ADHD, we had trained raters doing full structured interviews for all the kids who came through our clinic for care. And we were able to see that there was a subset of them who met criteria for mania. This was occurring even in the under age 12 group. So it led to this question of, is this really a rare disorder, or have we just been missing it? Or are we making a mistake in our structured interviews and calling something that it isn't? So at the time, the outpatient clinic, it was 16, 17% of our referrals were individuals, children who had bipolar disorder. ADHD, 3/4, 76%, much more common problem. And so how do you diagnose bipolar disorder in children? I usually kind of ask people, what do you think of when you think of mania? And people will say things like decreased need for sleep, or racing thoughts. The DSM, you guys probably know quite well, describes a distinct period of a mood that's either elevated, expansive, and or irritable. It doesn't have to be expansive, it could be irritable. And DSM-5 added this persistently increased goal-directed activity or energy. So they think it's a way of thinking about bipolar disorder, not just a mood shift disorder, but like an energy shift disorder. People have energy surges, and then they have decrease and times of very low energy. So dig fast is the mnemonic we commonly use. So we use all these same symptoms in kids, but we have gone to some trouble to think about it developmentally. One of my sort of mentors from WashU in St. Louis used to say things like, well, kids don't have credit cards to spend up on, although these days they kind of do. They go online and believe it or not, will spend up parents' credit cards, or they don't have multiple marriages. So it can be difficult to discern. In fact, I think euphoria and grandiosity are particularly difficult because we tend to think of kids as kind of goofy and silly and happy and hyper and high and like braggy and show-offy in a kind of a grandiose way, whatever, they're a rock star or an astronaut or whatever. And so we do ask about these behaviors in children, and we have to put it into some developmental perspective. So, I mean, for example, goofy, giddy, silly, inappropriate laughter, singing. If you were a group of kindergartners, this would all be happening, and we'd think it was cute and fun, and that's age 5. If it's happening with any of you here, we would be very surprised, because control over our emotions develops over time. And so then we have different expectations. By the time kids get to first grade, 6-year-olds, we expect them to be able to contain themselves, wait, stand in line, follow directions, sit still for a while, and not be so disruptive. Don't need so many adults to kind of take care of them. But it's these symptoms alone are usually not what brings a parent to any clinical office. We'll bring them all the way to Mass General. In fact, when I see kids who have bipolar disorder, these traits are often the things that make people smile, because they're kind of amusing and funny, because the child can be such a performer or can be so engaging. What's not so engaging is when there's a disregard for adult authority. And while defiance can be common throughout childhood, and I guess adulthood as well, one of the ways in which grandiosity appears in these kids is often labeled defiance. They have no regard for rules and authority, as if they are above it. Kids are often defiant, but to go to the point where they have no regard for rules is rather unusual. The kids will usually settle down, follow the rules, do their homework, do their chores, whatever it may be. One of our rating scales that we use, that we've been working on over the years, is a mania symptom checklist. So it's basically just going through the DSM dig fast symptoms with some prompts to help us think about how to ask parents and kids about these states. Asking if they're euphoric or elated is not necessarily going to evoke the stories that we want to hear. So we ask about being overexcited, silly, giddy, goofy, babyish, laughing fits, and then also the context in which it's occurring. So the quality, the quantity, the intensity, the context, all of that's going to give us a clue as to whether we think of it as something that's problematic versus something that might be appropriate. Euphoric when they go to Disneyland, okay, that's not going to be enough. And then there's the irritability. Irritability is usually what brings parents into the office, because these are kids who have sustained periods that are not just only angry, grouchy, cranky, whiny, complaining, but they are threatening, aggressive, and destructive in ways that are frightening to people. And sometimes parents feel held hostage by their kids during these times. I just got mentioning a few of these other symptoms. Preoccupation with sex. Can children be hypersexual? Yes, they can. I mean, there's certain normal interest in sex and sexual matters for kids throughout different ages. But these younger kids can be preoccupied with sexual remarks or bathroom humor in kind of very inappropriate places, touching themselves, touching other people, private parts, engaging other kids into sexual play. When that happens, usually people worry that they've been traumatized. It's possible they have been. That certainly can occur. But mania in children can also present with just a production of urges, aggressive, destructive, sexual, impulsive, reckless, daredevil. Um, a lot of parents are kind of horrified that they're very pacifist kind of people and their children are obsessed with killing and guns and fighting. It's just the thoughts that come to them. The grandiosity, how do we think about this inflated self-esteem? I sometimes ask about braggy and bossy behaviors, neither of which is a huge offense. It's kind of annoying if somebody's braggy or bossy, but it will elicit these stories of individuals, kids who overestimate their capacity to do things in a way that is unrealistic um, or actually may put them in harm's way. And then psychosis. So we ask about psychosis, unusual experiences, hearing voices, seeing things that don't exist. The trickier ones, I think, are grandiose or suspicious or paranoid behaviors that are out of touch with reality. I think they involve a little bit more of a judgment call. And in our clinic, we usually called something psychosis if it seemed quite clearly out of touch with reality, hallucinatory, or quite bizarre in the delusions. And I'll get back to that a little bit. So to kind of cut to the chase from all the things we learned of these youngsters with bipolar disorder, these were kind of some of the key things that we took away that maybe makes their picture look different than what you might think of as a classic individual with bipolar disorder. So the chief complaint of the parents was usually severe irritability. Euphoria was often present, but it wasn't the main presenting problem or the thing that was causing the most difficulty in their lives. The children mostly had mixed states, and so that made it quite difficult as well. And a lot of clinicians will see the depressed part of these kids. They're hopeless or self-destruct, self-harming, or even suicidal, but miss that there's manic features. And in DSM-5, they actually made it easier to diagnose mixed depression with mixed features. And that was the group that treats adults felt like we were missing a number of adults who actually had bipolar disorder and not unipolar depression. Oddly, in the DSM-5 committees, the child group was trying to minimize the number of bipolar diagnoses that we were making, kind of raising the bar for what the criteria might be.
We have another question actually in the chat. Asking if we see discrepancies in their symptom presentation across various settings. So, for example, there's persistent irritability and behavioral dysregulation at home
Yep.
versus none of those concerns at school. Is that kind of evidence for or against bipolar disorder?
Uh, well, what I would say is that I'll tell you a story about that. When we first started working with these kids, we'd have these round tables to kind of decide if we could come to some consensus about how to make this diagnosis. And some of the researchers said, well, you can't make the diagnosis unless the symptoms cross a number of different areas of living, school, friendships, home. And the parent advocates who were sitting in on all of this said, well, if you do that, you're going to delay a diagnosis for a lot of these kids because most of the parents said that by the time that the child started to show these behaviors outside of the home and school settings, for example, or social settings, they had already been having very severe symptoms only in the home environment. Now, why would that be? How could it be that you'd have such severe symptoms in one place and not another? I don't know. I've speculated about it with parents and researchers. One way I think about it is that if there's a problem in the emotional center of your brain, it's going to come out when you're around people you're emotionally connected to. So kind of like your mother is like a stress test for your emotional resilience. I think that may be true for just about everyone. I'd like to put these kids in the fMRI, have them hear a teacher's voice, and then have their mother's voice telling them something. I think that they will react quite differently to it, internally and externally. Another thing is that sometimes people will, I think of this as children who hold things together in these other settings, working very hard to, because they recognize the repercussions outside of the home of letting these things out and expressing themselves in the way they do at home, aggressive or destructive. And so they can be exhausted at the end of the day. You might say, well, if you could do it at school, why can't you do it at home too, or everywhere else? And one of my colleagues said it's kind of like those teaching dogs to walk on two legs. They can do it, like they do it in the circus, and it looks like, oh, look at dogs can walk on two legs. Oh, and then expecting them to do that all the time. Well, it's very hard for them to do. They'd rather not. They'd rather be down on all fours. Same thing for people with mood disorders who may be holding things together in outside environments. Um, so the answer to the question is it's a piece of information that we take in. And of course, if things are happening only in one arena, we do worry whether there's something about that arena that's particularly stressful or evocative, if somebody's being harmed or stressed or traumatized there. But I will tell you that over the years, plenty of parents have been accused. It's only happening in your home? Well, you parents must be doing everything wrong. The irony about all of that is when it only happens at school, the teachers say, you must be doing something wrong at home. So all roads lead to blaming mom, usually. And your psychosis group, so you've heard of schizophrenic mothers. There was a time when we thought schizophrenia could be caused by poor mothering. And even in my med school years, I was taught that autistic children had refrigerator mothers, that mothers who were cold and uninvolved ended up leading to having autism in a child. So I think our tendency is always to blame parents, and it doesn't help any situation. So my tendency is usually to avoid doing that at all costs. So we were talking about symptoms. If your vision of bipolar disorder is like, I call it celebrity bipolar disorder, Carrie Fisher, who writes a book and says, I have euphoric times and energy times. I talk and I don't sleep and I get very excited and paparazzi takes pictures of me doing wild things. Then a month of depression and hopelessness and, inside, closing the windows, under the covers, unable to function, and then kind of come out of it, like an intermorbid period of high functioning, where she writes her books, and she goes on tour, and she talks about her bipolar disorder, or talked. This is a past tense for her. But there's a number of like celebrities who kind of have that form of bipolar disorder, and that does exist among adults with bipolar disorder, but it turns out even among the adults, it's a minority of individuals, and among kids, it's really quite unusual. We see much more mixed states and these kind of seldom well pictures that look more like chronicity. It's not that they're not changing at all. It's like constant changing, but it's chronically impaired, I guess is probably the better way to put it. Irritability is usually, in addition to the arena, is it present in different arenas? I also have people say, well, how could you just use irritability as a symptom of mania? Irritability is so common. We're all irritable for different reasons all the time across all diagnostic categories. And it even led to this diagnosis of disruptive mood dysregulation disorder in DSM-5. This was part of that DSM-5 committee where the child group was saying, we can't be diagnosing all these kids with bipolar disorder. We have to have some other way to talk about them. If they're really all quite irritable, let's make an irritability disorder. And this disorder, I would say, has generally been agreed upon that it hasn't added value to our work. It's classified as a depressive disorder. So it's in the depressive disorder category in the DSM-5. And it's mostly focused on temper outbursts and irritability in different settings and for different periods of time. And it's got a lot of different criteria, but any manic symptom is an exclusionary criteria. So, it's a disorder that I think probably captures kids who are depressed, because kids who are depressed, irritability is part of that too. They can be melancholy and sad and blue and down in the dumps, but it's more likely that kids who are depressed are grouchy, cranky, complainy, whiny, bad tempers. So when I get a child who's been diagnosed with DMDD in my clinic, I don't know if the person diagnosed them according to the letter of the law in which case I think it's more a form of depression and I'm going to treat them with antidepressants, or whether they think the child might have bipolar, but they don't want to say the word. They're worried that, that they're going to label somebody with a bad diagnosis incorrectly. In which case, you should bark up the tree of the bipolar medications. So it's a really important decision tree moment for us in terms of what to do pharmacologically. And I think we need more work on this biomarkers for this in particular. And it's a problem in adults too, right? Adults will go a decade getting antidepressants before someone says, I think you actually have bipolar disorder. It's interesting in terms of irritability that we've got two medications that are FDA approved for symptom of irritability, risperidone and aripiprazole. You know, many of our medicines, I remember probably most of them, are FDA approved to treat a disorder, you know, bipolar disorder or schizophrenia. These are approved for irritability in individuals with autism. And at the time that those studies were going on, I was thinking, they're treating individuals with autism who have pediatric onset bipolar disorder. Big surprise that risperidone and aripiprazole would work. Not, because those are FDA approved for pediatric bipolar disorder as well. So I think it speaks a little bit to our concern about using the term bipolar, and also how we understand irritability. I think that it's a little bit like saying to you, oh, you can't diagnose anyone with depression because doesn't everyone get kind of down in the dumps and blue from time to time? Well, it's quite qualitatively and quantitatively different, right? And that's the same for the irritability that we see in these kids. So back to your, for the first question was the symptoms that we see. If your vision of bipolar disorder, your first thing you say is decreased need for sleep, that does occur in these kids, but it's one of the least common symptoms that we have. The other symptoms are all much more common, and irritability is really usually why people are walking in the door. This is data from two different cohorts of kids. They came in for clinic evaluations, so this was clinic samples, not research samples. Their average age, we parsed out the under age 12. The average age of that group was 8. And when we asked parents when these symptoms onset, 75% of them said they were in preschool years, age 5 and under. So this is really a disorder of preschool age of onset. And yet the number of preschool studies we have are very, very, very few. And it's easy for me to see an 8-year-old to hear the story backwards and say, oh yeah, that was a lot of symptoms that your preschooler had. But we don't have any studies that take all of the emotionally dysregulated preschoolers and see which ones of them with the rapid growth and development of the brain between ages 3, 4, 5 to 6 actually settle down and become emotionally better regulated. So it's much harder to diagnose a preschooler because we don't have a sense of which ones will get better. What do we do in those cases? We look at quality and quantity of symptoms and decide on that risk-benefit ratio of whether it makes sense to intervene with a medication if we think that it's bipolar-like illness. But one of the points,
Another question actually, yeah, in the chat. So what is the best way for caregivers and parents to support a child living with this diagnosis? What would you recommend?
treat their symptoms, I guess, first and
Yeah.
foremost. And in fact, when you have a lot of our child fellows will present cases and they'll say, oh, the parent is so difficult, they're always complaining and needy and calling me. And I'm always like, well, treat their child and then they will stop bothering you. Address the symptoms that are making their life miserable. So we tend to think of like you clear up these symptoms really for just about anything in childhood. ADHD is another one too. And then you make way for normal development to occur. So I would say that that's number one. From a non-medication standpoint, the best approach is something we call collaborative problem solving. And so common parenting, you know, from your grandma and everyone else, and you know, people in the convenience store where you take your kid, is like be firm, say no, set limits, don't back down. And it turns out that for the kids like this, they just see red. This disregard for adult authority kicks in, and they go face to face with that adult, and it turns into a big scene and a big blow up, more outbursts, out of control aggression, more rage. And so we train parents to, some parents kind of come to it naturally because they've recognized that star charts and sending kids to their room just doesn't work and only makes it worse. But specifically, we train in collaborative problem solving. We've got Stuart Ablon is a guy at Mass General who has a whole program dedicated to collaborative problem solving, clinical care, and teaching in different settings, schools and other places. And it can be a challenge to tell parents that when their child wants ice cream for dinner, that maybe you should consider ice cream for dinner with them and wonder why it is such a bad idea. And is that something I really need to prohibit right now? So it doesn't mean that you let your child run wild, but it means that you collaborate with them when they have their demands rather than setting these firm limits as an authoritarian.
Right. And actually, we've gotten a good number of questions coming in. So a couple of quicker ones, but is there longitudinal data on DMDD as far as what people tend to develop in later life? So, bipolar versus unipolar depression, et cetera.
Yeah, the original DMDD data, by my reading, was that the kids had comorbidity with depression and ADHD. Big surprise. And so then the wisdom was these kids who are severely irritable should be treated with ADHD medication, stimulants, and antidepressants. Um, and then some other longitudinal studies showed that sometimes it was a transient problem that just went away. It wasn't particularly severe. Others would see that it would morph more into ADHD and conduct disorder kind of kids. And so what this speaks to is the spectrum of irritability. How do we understand the quality and quantity of it? What kind of questions do we ask? And if all you're saying is your child irritable? You could have 10 parents say, oh gosh, yeah, and mean completely different things, from a child who occasionally whines and complains to somebody who is terrifying. Um, so when we think about the irritability of mania, we are looking for a type of irritability that's well out of proportion to the event and involves hitting, kicking, biting, spitting, swearing, out of control, destructive, aggressive, threatening, attacking. I mean, these are really serious symptoms. And there's plenty of kids who have irritability because they have ADHD. I don't want to do my homework. No, you can't make me. Oh, I hate my homework. I hate you. So there's grouchy that. There's kids who are irritable because they're anxious. Don't make me do that. I hate you. I'm not going to get up in front of the class and talk. I refuse to do that. There's kids who are irritable because they're depressed, right? Oh, I don't like it. I hate it. It's never any fun. I'm not going to do it. Why are you making me do that? You're so stupid. That's all quite different when you hear these stories of these parents. I remember there was a reporter once that kind of asked me some kind of a similar question about this, how do these kids present? And so I gave some of these stories about uh, the dangerousness of these outbursts and how frightening they are and how police get called and how other children are scared and siblings are terrified. And the reporter said, oh my, you're talking about children who have a really big problem, are really disturbed. I'm like, yes, that's exactly what we're talking about. It's not as if any child who's grouchy or cranky is getting a diagnosis of mania from us. Um, we're looking for a qualitatively different type. It's a little bit like saying, I think some people say, well, irritability is like fever. It could be caused by anything. But even fever has different patterns. There's low-level fevers, there's super high fevers, there's malaria fevers that kind of come and go. Headaches, are headaches all the same because you have an ache in your head? No, there's different quality and quantity to headaches. Some of them are migraine, some of them are other, cluster, etc. I think we need to be better about understanding this range of irritability, not only to make diagnoses, but once you're treating somebody, when they have more irritability, to have a sense of like, okay, what do I do with this? Do they need more anti-manic agent? Do they need antidepressant? Is this for ADHD? Is this irritability that's associated with anxiety? It's it's like a spectrum or flavor. Like sometimes I used to say like the Inuits have like dozens of words for snow, the different quality and types of snow. And we need more ways of understanding and communicating with each other as clinicians about this particular symptom of irritability. As a kind of an aside, what's the next one? Oh, irritability is also a symptom of depression, right? Grouchy, cranky, whiny, complaining, difficult to please. And I remember talking to somebody, it might have been Gay Carlson or a child psychiatrist who was involved in the very early DSMs. And I said, it's one of the things that is kind of been difficult in our field now is that irritability is criterion A for mania. We know that kids get irritable and adults who have depression are irritable. Adults aren't always, there's melancholy and crying and sad and blue and hopeless and I hate myself and I hate my life. But there's also short-tempered and difficult to please and get away from me and that's so stupid. And there's that type of irritability that happens throughout the life cycle for depression. And we see a lot of this in kids. School refusal, stomach aches. And so I said, well, why is it? And she said, well, we know that irritability happens in depression, but we didn't want anyone to miss a bipolar diagnosis because the impact on your treatment plan, the medications that you use right then is very critical. You could make somebody worse and have a more treatment resistant course if you give them the wrong medicine at that juncture. So she said, we put irritability in mania because we wanted to make sure people were really thinking about it as a manic symptom and not missing bipolar disorder when it was bipolar. No. So this is a very different type of irritability. When one of the residents comes and says the mom says the child's very irritable, I'm waiting. What type of, tell me about the irritability. What is it? They're grouchy, cranky? They're complaining, whiny? Or they're terrifying, hitting, kicking, biting, spitting? With some of the kids I see, I used to ask, is anything in the house destroyed? And then I started to ask, how many holes in the wall do you have? Because kids would make holes in the wall when they would get in one of these rages. It's hard to make a hole in the wall. If you've ever tried to do that, the walls are very hard. So it involves a lot of constant aggressive breaking and hitting and pushing, kicking and whatever. It's a big problem. So yeah, these kids are quite out of control and in this rageful way. They also can have this, right? So if you have a mixed state, you might be kind of going in and out of 4 different mood states. One of the parents called their kid a 5-pointed star. There was like, sometimes they're just a normal kid. It looks like they're kind of doing okay. Sometimes they were whiny, complainy, grouchy, and cranky. Sometimes they were rageful. Sometimes they were melancholic. Sometimes they were giddy. Like the one little girl would wake up in one of these states. I hate school. I hate my life. I don't want it. It's no good. I won't wear that. I'm not taking the bus. I don't want that breakfast. Why are you making me go to school? It's no fun. Goes to school, comes home off the bus, super excited. I got invited to a party. Guess what? This person, pressured speech, extreme excitement, very high and hyper, starts to say, I need to go shopping. I need some more clothes. I need 2 dresses. No, I need 3 dresses. No, maybe I need a cell phone. The mom tries to say, no, we can't go shopping. The kid explodes in rage. You never give me anything I want. Kicking, hitting, biting, spitting, throwing things, terrifying, goes on for 30 minutes, 60 minutes. As time settles down, the child kind of dissolves into tears. Why do you love me? I'm terrible. Life is hopeless. You should just kill me. I can't do anything right. Kind of sad, melancholy. So from a parent standpoint, it really is a roller coaster of Dr. Jekyll and Mr. Hyde mood shifts that these children have throughout a day, triggered by small precipitants unexpectedly. Usually people will say, well, it's always triggered by something. It never comes out of the blue. But sometimes the thing it's triggered by is, hi, how are you? Which I guess I would say is more or less out of the blue. It's kind of a big reaction to a small precipitant. No, we're having spaghetti, not chicken for dinner. Well, that's not a reason to have one of these dramatic explosions. Um, so right. So they have this kind of mood reactive quality. They have this mixed state. They have all of these symptoms together. If you're expert at treating depression, you'll see their depression and maybe call it depression, unless you ask about other symptoms that might be related to mania. If you're expert at treating ADHD, which I haven't even gotten to yet, then you are going to see the ADHD, and then you might just treat that, not thinking about a mood disorder. So it's really important when we do our interviews, when we hear, to recognize that there's comorbidity and to ask all of the different questions.
And another related question to that, can you speak to any gender differences in the presentation that you might be thinking about during an assessment?
Yeah, we did. I wrote a paper on gender differences a long time ago, and really the bottom line was that there were more similarities than differences. Um, and it's even true for ADHD, although I do tend to think that girls are disruptive in a different way in classrooms than boys are. And so sometimes the boys come to greater attention because their disruption can be involve more aggressive or destructive type impulsivity or play. And the girls may be more spacey or chatty or overly social, or in a different kind of way, but they still have those symptoms. They just may manifest. All the symptoms are really, they check the same boxes. But it may manifest in a slightly different way. People talk about autism that way too, that girls with autism often go undetected longer than they should because they have a sort of veneer of social skills and capacity that their mother or parents may help put in place, or they have just a little bit more of a capacity to mask and pretend and kind of do what the other kids are doing than the boys do. Um, but the symptoms are all really quite the same. It is male preponderant, and most studies have more males than females for bipolar disorder. It's interesting because I think in adults it's more even, 50-50. And I think depression is thought to be more common in women than in men. And so there's clearly some differences. But gender-wise, I would say that we see more boys than girls, but the girls present in very similar ways. So if you think that bipolar disorder has to only be euphoric, that irritability doesn't count, that mixed states that I described, although that's not a mixed state, that's, I don't know what else you think, that's a kid who's got ADD or depressed. And if you're looking for a clear cycle, Carrie Fisher, I was manic, I was depressed, I was fine, then you're not going to diagnose this in these kids. This is not that you're not going to see it as bipolar disorder because the kids don't have clear, neat cycles. It's not that they don't have worst times. They definitely do. This is just an example of, one of our cohort groups. This classic euphoric mania alternating with depression it occurs, but it's more of a rare type. And these mixed states are much more common. So remember I told you DSM-5 made it easier to diagnose a mixed state. So if you have major depression, it's considered mixed if you have 3 out of 7 of these additional manic symptoms. Now, if you've got a kid who's got ADHD and they're talkative and their thoughts are quick and they've got a lot of high energy, or they do something impulsive and reckless, you need to be cautious about that, because I would say that to have symptoms of mania, it's not just the ones that overlap with ADHD. It has to be mood symptoms based. It has to include the euphoria, elation, and or the irritability. And the euphoria elation can sometimes be difficult to discern from developmentally typical states. The irritability that I described is clearly out of range for kids at really just about any age, even preschoolers. Most of them aren't spitting and biting people all the time. So at any rate, this was the goal, was to not miss the diagnosis of bipolar disorder, so you don't make sure you give people mood stabilizers when they need it. And then this speaks to this idea of the different forms of irritability that coexist. So there are cycles. There's mixed moments. There's more depressed moments. There's more manic moments that can go on for days or weeks at a time. But even when the moods are settled down, you have a child, ADHD is extremely common comorbidity. And so in the under age 12 group, maybe like 95% of them check all the boxes for ADHD. What the parents used to come in, in Boston say, wicked bad ADHD. That was the diagnosis that they often had already had. Um, and the anxiety disorders, and well, I can talk about those in another few minutes, and psychosis too. But these different forms of irritability, they coexist, they overlap, and they lead to this kind of never well condition, which is not the same thing as not cycling or chronic. And I think maybe that is important. One of the things about DMDD is that it doesn't cycle. It's kind of more of a chronic condition. And I think that the hearing that we were diagnosing kids with irritability that was chronic led people to say, well, that's not bipolar. So by chronic, what I mean is never well. And the cycling can occur. And I ask parents all the time, when is this part of the clinical picture worse? When are they most rageful? When have they been most rageful? When have you seen the most depression? We sometimes will see kind of seasonal stuff like you see with adults. Okay, so now we're finally getting to ADHD. How can I be convinced these child don't just have a severe form of ADHD? Because they're super active, they're talkative, they're impulsive, they're irritable, they're defiant. And we did in fact see that they checked all of those symptoms. Yes, 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 they have all the symptoms associated with inattentive, hyperactive, impulsive ADHD. So first thing we noticed was, okay, this is interesting. Way back when I first started this in the mid-90s, my skepticism was, oh, wait a minute, how can we call this mania if all of these symptoms overlap? If somebody has ADHD, they've already checked the box for like 4 of the dig fast, right? Because talkativeness these are all ADHD symptoms. And then when DSM-5 added increased energy, it seemed like, well, these ADHD kids are really kind of fitting the bill here. But the key really has to be the abnormal mood state. So like I say to the trainees, if the parent comes in and says their child's very moody, you have to think that there's a mood disorder, even if there's also ADHD. So we spend a lot of our time asking about the moods. And I ask about them in the way I described, the euphoric ones, the grouchy ones, the rageful ones, and the melancholy ones. And that's how we think about the diagnosis, and we make this diagnosis. So we spent a lot of time trying to think about ADHD. So it's interesting in my, I'm talking to you guys today about pediatric bipolar disorder, ADHD, psychosis. Psychosis is not a symptom of ADHD. It's not a correlate of ADHD. It's associated with the comorbidity that comes with ADHD. And as you can see, of their ADHD population, maybe by 20% of our ADHD population also meets our criteria for bipolar disorder because of the degree of emotional instability, mood symptoms. The opposite is kind of a bidirectional and asymmetric. Most of the bipolars check the box for ADHD. So one question I get is, how do you know this is not just ADHD? But another question that I get is, why do you think that bipolar people have ADHD? Isn't that mania that you're describing when you talk about them being impulsive or hyperactive? No. But let's talk about the first one first. So how do we know it's not just ADHD? We parsed out the kids who had mania, and most of whom had ADHD. And we parsed out the kids who had ADHD without any symptoms of mania or depression. I'm sorry, without any symptoms of mania. And so depression is a correlate of ADHD. And we think, wow, if 40% of kids with ADHD get depressed, that's true. It's not just demoralization. They have bona fide depression. So it's important to screen for that in ADHD individuals. But among the manic kids, it's really almost universal. We have really a rule of thirds with these kids. A third of them start with mania and go on to show depression. A third of them start with depression, go on to show mania, and a third start with mixed state. Psychosis, our rate was 16%. And And let me tell you a little bit about how we diagnose that and what other groups have found. Oppositional defiant disorder is a disorder of child we use in child and adolescent psychiatry. I tend to think of that one as being a lot more like universally present because you can be defiant for so many different reasons. You might be defiant because you're being asked to do something that's hard to do, like if you are anxious or depressed or you have ADHD. But the defiance that we see in these children with mania is that extreme flagrant disregard for adult authority, where they come into my office, they will refuse to even talk to me. They'll insult me a few times, and then I'll say, let me talk to your parents a little bit. And they may storm out, and it's a kind of enraged. It happens in schools when it bleeds over into these other settings as well. Conduct disorder. Conduct disorder is not just a little bit of childhood misbehavior. It involves bullying and lying and stealing and vandalizing, but it really is pre-sociopathy. So if you wanted to say to me, if only we could find the individuals who are going to pose a problem in our criminal justice system at an early age, kids with conduct disorder. We know that it tends to convert to sociopathy at high rates. And almost 40% of the kids, these are kids under the age of 12 at this point, present with conduct disorder symptoms, which I think is a huge question from a number of different standpoints. One of them, public health, of course, but another is if you have mania and you're lying and stealing and bullying and vandalizing, is that because you have sociopathy or is that because you're disinhibited from the mania? In other words, for some individuals who have conduct disorder, if they have comorbid mania, could you treat it and have the conduct disorder diminish or go away? We don't have a pill for sociopathy. We don't have a pill for criminals who do criminal things. But if there's a co-occurring condition like mania that may be fueling those behaviors, then it holds some hope of diverting these young individuals from criminal justice system early on. Anxiety. Present in ADHD, quarter of the kids with ADHD have significant anxiety. It's really a hard problem to treat because stimulants make people more jittery and anxious, right? Like caffeine effects. And medicines for anxiety don't help ADHD. So you're kind of bound to have some type of combined pharmacotherapy for that problem. It's difficult to treat. But isn't it interesting how many individuals with mania have anxiety? This is not just in kids. Around the same time, we were learning that adults with bipolar disorder also can be very anxious. And it's can be confounding to think about, right? Because I had an adult manic patient years ago, early in my training. He was full of all this swagger and defiance and impulsivity and the grandiosity, all of it above. And one day he came into me and he said, I'm so terrified, I don't even think I can leave the house. And I thought, he's gaming me for benzodiazepines or something. This can't be true. But it's true. Sometimes parents, I'll say to parents, separate yourself from this child when they're having these rages, and they'll be like, I can't separate. They'll have a panic attack. They can't be in a room alone. They're terrified. They're too scared. They're needy. They constantly need reassurance. They're nervous and anxious and on edge. They kind of check all the different boxes for anxiety. So also, the medicines for bipolar disorder don't necessarily get at anxiety. So if somebody's still somewhat irritable or defiant, sometimes I'm wondering, is this because we haven't treated the ADHD or we haven't treated the anxiety? It would depend on the circumstances in which the symptoms are occurring and the quality and quantity of them for that. Hospitalization, 2%, I don't even know why 2% of the ADHD group got hospitalized. ADHD is not a reason to be psychiatrically hospitalized. You get psychiatrically hospitalized if you're putting yourself or others in harm's way, if you're suicidal, or you're dangerous, you're reckless. So at this point, with this cohort of kids I'm describing in our clinic, under the age of 12, 21% of them had already been psychiatrically hospitalized. So it's just another indicator of the severity of the symptoms from whatever direction you want to think about it. Bipolar and ADHD, does it happen in adults? Well, yeah, these big, large surveys show that there's quite a bit of overlap, right? So 34% of the ADHD individuals had bipolar disorder versus 6% of those who didn't have ADHD. And in the National Comorbidity Study, similar statistics. I used to call this, I think it may still be in a way, kind of an orphan condition, because adults adult people who are trained in adult psychiatry or treating adults with bipolar disorder don't have a firm grounding or education necessarily in identifying and treating ADHD. Certainly in the old days, we even thought that it didn't even exist in adults. It was a childhood disorder that people kind of would grow out of. And for years, before we started to identify bipolar disorder in children, ADHD was clearly evident. And so these children would be seen from the lens of a child psychiatrist. What's our lens? Our bread and butter? ADHD. Before I even get any information, you're telling me there's a new child coming into our clinic. If I say, I bet he has ADHD, I'm probably going to win the bet because it's like 3/4 of those kids do. And it's a very common reason for referral because of it's a disruptive disorder. But the combination exists and is worthy of study. So this is going back a little bit to psychosis. So I told you 16% of our group was we had coded as psychotic disorder in the bipolar individuals. I went to go visit Dr. Geller out in St. Louis many years ago because I noticed that her group looked different from ours in a number of ways. One of the ways was the high rates of elated mood. Well, I didn't highlight it, but it's over here, like 80. Let's see, 83%. Is that right? No, 83 total. Yeah. I'm looking now. Is that a percentage or is that out of the total? It's the N, it looks like. Right. And so 83 out of 90, almost all of them. And the psychosis we've got, right? Grandiose delusions and total psychosis, different from my 16%. So here we are, we're a group of people talking about psychosis. How do we understand that? It had to do with the threshold for calling something psychotic. And I think by some standards, just about every kid I see with pediatric bipolar disorder has psychotic moments. And if I were to ask any of those parents, do you think your child is out of touch with reality at any of these points in time? They'd be like, oh, absolutely. They're making a hole in the wall because I didn't give them spaghetti for dinner. How does that make any sense? After they're done, they're surprised themselves at what they've done. They're apologetic. Sometimes they don't really even remember it. It's like looking on at some other kid. So it's never really a big surprise to parents when I say the best treatment for pediatric bipolar disorder is going to be a medicine in the category we call antipsychotic. In psychiatry, psychotic means out of touch with reality. They're like, oh yeah, I get it. My kid's definitely out of touch with reality. And that's what's causing so many of these problems. So I make a rate of 16%, but those are kids who have hallucinations and delusions. They're the kids who maybe we might have more of difficulty distinguishing from early onset schizophrenia. Because the psychotic symptoms are kind of so really quite bizarre. The grandiose delusions that Dr. Geller would call. I can't remember who I told. Maybe I told Kelsey or this story, but when I went to hear them listen to their structured interviews, they had a child who said to repeatedly would get up at school, yell at the teacher, "Fuck you, you're stupid," and storm out. And she said, okay, that's grandiosity, this disregard for authority, thinking that they're better than everyone else. And that's psychosis because it's really delusional that they think that they're better than the teacher. And it's also hypersexuality, that was the one where I said, hypersexuality. And she says, well, they used a sexual word when they swore at the teacher. So yeah, people have these different thresholds for deciding what to code, and it may help understand why we have different have different statistics that we show. But I think she was embracing the same group of children that we were embracing for sure in our studies. And then in terms of the euphoria, how could she have such a higher rate? Yeah, I think I showed you the scatter plot. Maybe 30% of the kids we have. When we did our structured interview, we asked this question: does your child have severely impairing euphoria, elation, giddy, goofy, silly, hyper moods that last 4 days or 7 days? Yes, no. And the parent might say, oh, maybe, but they don't have it for 4 days. It's not really impairing. And then, so that would be like no. And then I'd say, how about irritability? 4 days or longer of extremely impairing manic level irritability? Yes, that's kind of how they would entree into our diagnosis. In other places, they would ask the question this way: has your child had 4 or 7 days of highly impairing euphoria or irritability? And describe those different things. And the parent would say, yes. And then the interviewer would say, was there euphoria present? Yes. Was there irritability present? Yes. So you see, in that way, the euphoria is counted, it will appear in a much higher percentage rate than we had. We were looking for impairing euphoric episodes lasting at least 4 days or 7 days to get them into the diagnosis. If we asked it the other way around, it's true. Just about every kid I see has these moments that are over the top. Would qualify for the elated category. Now, it's a tricky one though, because being a class clown doesn't mean you have bipolar disorder. There's a lot of reasons why a child might be telling jokes and making their classmates laugh all the time. But when you hear it, it starts to raise my suspicion to ask all of the other questions. One parent said, my 5-year-old disappeared. We called the police. We had a whole neighborhood search. He actually wandered back in. And I said, where were you? And the kid said, I came back to get a blanket because I am doing a survivalist camping trip. And so I'm out there in the woods. And so I wanted to get this blanket because I need it for the trip, for this event. And mom said to me, what is that? It was like, is that grandiosity of mania? In and of itself, I don't know what to make of it. I want to ask all the other questions to see if it's part and parcel of the rest of a manic picture. It might not be. It might just be an impulsive kind of cute story for that kid. The girl comes home, textbooks galore. She says to her mother and her grandmother, I'm going to solve the ozone problem. The grandmother says, oh, I'm so glad she's interested in science. And the mother calls me and says, this is weird. She is not interested in science. She thinks she can solve an ozone problem. And she's right now going through these books, highlighting everything. And mother and I both agreed, this was a girl I was already treating for bipolar disorder, that this was a harbinger of a manic relapse for her. But in and of itself, somebody comes home and says they're going to solve the ozone problem, you might think it's cute. So context, I guess, is important for all of the different symptoms.
And I said, yeah, I want to do both still. It shows on my timesheet.
Whoops, I think that's not for me. But so this, I wanted to show this slide because we get these kids in our clinic. I do triage for our outpatient service, and there's psychotic symptoms that are present. And so I will sometimes send to my first episode program person, Abby Donovan. Maybe you've met her already. She's great. And I'll say, read this. Do you think this is a person for your program? Well, first of all, if they're under the age of 13, it's very unlikely, right? It's not schizophrenia does not start at that very, very early age. That very early age of onset is unusual for schizophrenia. And if it's in the adolescent range, if they also have mood symptoms, if there's aggression or rage, or a lot of these kind of externalizing behaviors, Abby's more likely than not to say, I think it's probably not going to be a first episode kid. I think it's going to be a kid who has mood disorder, autism, anxiety, all of the above. Not that they don't have psychosis, and we do kind of share cases all along, and she could certainly see them, but that clinic is really reserved for first episode schizophrenia. And then the moody kids, we see more over in the bipolar clinic. So I would say that it's when we see psychosis coming in as what part of the chief complaint, more often than not, it's associated with mood problems as well. And more often than not, we are thinking of them as pediatric bipolar than we are thinking of them as schizophrenia. Not that we don't see these kids. And there are certainly ones that we're puzzled by and we don't know. It helps that the treatment that we use for pediatric bipolar disorder is our antipsychotics. Where do we go here? I'm just going to tell you a little bit about treatment. Powerful medicines for little children. These are the FDA-approved medications for manic and mixed states in children, down to age 10 or down to age 13 for all of these different antipsychotics. Same medications we would use for a first episode psychosis. So you don't have to put your dime down and say, I know exactly what the disorder is when you start to treat these children. The medication choice is going to be the same. And then over time, you can look for whether they parse out to seem to have the negative symptoms of schizophrenia, the cognitive decline, less of the emotional dysregulation as part of their clinical picture. Some of the kids who grow up from my clinic, I see them be called schizoaffective in other clinics. Bipolar, schizoaffective, I'm not going to argue. It's, they've got mood problems, they've got psychotic problems, and they're going to get similar medication treatment. I mean, these are spectrum kids. We've started to use the term bipolar spectrum because we also recognized that if someone doesn't tick every single box, doesn't have 4 days, 7 days, you shouldn't just send them home. There's one of my colleagues in Pittsburgh did their longitudinal study, and they followed kids with bipolar disorder, subthreshold bipolar disorder, and something they called bipolar not otherwise specified. So these were kids who came in, it was a very low bar for a manic-like symptom. 4 hours in 1 year that they had symptoms that seemed either related, grandiose, or I don't even know if he included aggression or rage in it, but certainly those symptoms. And when he followed these kids over time, like a quarter of the NOS kids convert to bipolar type 1 or type 2, if not more, maybe 40%. And in the subthresholds, a high percentage of them eventually convert to bipolar type 1 as well. In other words, I guess they read the book and they realize they need a few more symptoms. They demonstrate those symptoms, and now they qualify for the other diagnosis. Does it matter if you're bipolar 1 or bipolar 2? In some studies, bipolar 2 people are harder to treat and have more morbidity. In our pediatric world, the bipolar 1s and the bipolar 2s and subthresholds are similar in course and characteristics and in terms of their impairment and morbidity. So let's see. Any questions that I can take for you guys? Otherwise, I'm just going to say a few quick things about treatment, but interrupt if you'd like, Kelsey.
Yeah,
These are
nothing coming up in chat so far, but
okay. Yeah, my pressured speech has bowled everybody over. I treat kids with medications, and there are some parents and clinicians who will say, if you've got a kid who's got a problem, do every other intervention. Get them a new school, get them a therapist, do all these other things before you resort to medications, because these are children with developing brains. We don't know what's going on. You're really going to give them a medication, you might do harm to them. I gotta say, in my decades of doing this, I have kind of an opposite feeling about it. And the feeling is the earlier you intervene to interrupt some aberrant course, the better off that individual is. The less treatment resistance they have, the more likely they may not need medications later on. I mean, it kind of stands to reason. It's true. I don't have a study to show you for that. I would love to, so I could kind of help parents feel confident that treating is a good idea. But at each time when I work with a parent, it's always a shared decision, and we're always looking at the risks and benefits. And part of the risk is the symptoms that are right then and there. Symptoms that are right then and there, they're scary, they're daredevil, they're reckless, the child's in harm's way, they're putting other people in harm's way. That kind of seems like a no-brainer. You've got to interrupt that. But even for kids who have ADHD, we talk about, it's not we want them to get A's instead of B's and C's in their grades. They feel bad about themselves. They're developing their sense of self and who they are. And if they have these symptoms and people are reacting to them in this way, I got to stay away from you. You're creating a lifelong problem for this child. So getting rid of those symptoms immediately is important. But also, what are the, I always say bipolar disorder is associated with the three biggest, baddest outcomes we could have, suicide, addiction, and criminal arrest. And if there's some way in which we can interrupt that path, well, we have to do it. Parents will sometimes say to me, what if my child grows up and says, I can't believe you gave me that medicine because it gave me this or that side effect? And I said, well, what if your child grows up and says, you mean there was a medicine you could have given me that might have prevented all of this and helped me on a better course? So I'm not saying we have the exact answer to it. It's a case by case, it's a shared decision, and it has to do with the side effects, you might say, of not treating. We know the side effects of treating, weight gain, tardive dyskinesia, whatever else. But what's the side effect of not treating? It exists, right? Our algorithm is very simple. Second generation antipsychotics are really the first choice. Lithium has long been FDA approved for pediatric bipolar disorder, but actually the first double-blind randomized controlled trial was done in 2015. And kids did well on it. It's definitely in our armamentarium, but they didn't do as well. We don't have a lot of head-to-head trials, but we do have this head-to-head trial. Barbara Geller, my St. Louis friend, risperidone, lithium, or divalproax. Guess which one won? It was the risperidone. More kids got better more robustly. And that's usually what I say to parents about the second generation antipsychotics. More kids get better more robustly and quickly. The double-blind phase for atypicals is 3 weeks. For lithium, 12 or 16 weeks. We have to watch it to kind of get positive impact for kids with that. So it's not that I love antipsychotics or think that they're perfect medicines or that all children should have them. So they're certainly not vitamins, and they certainly have serious side effects. But to treat this disorder, if you really want to, what's the horse that's going to win the race? It's going to be an atypical antipsychotic. These others, they're in our armamentarium. These days, there's other ones too. Lamotrigine, for example, is one we think of especially for depressive phase of things. We all have unique responders in our clinic to any of these. And when I first started working before, believe it or not, it was before there was even risperidone, the first SGA. We used to use lithium and carbamazepine all the time as our go-to combination for bipolar disorder, even in younger individuals. So these medicines work. But if you look at like response rates for the SGAs, they're like in the 70 to 80% range easily. So, and what else did I want to tell you? Tardive dyskinesia, weight gain, comorbidity. Let me take a few words about that, unless anybody wants to interrupt me. This will be the last slides I show. The kids are very comorbid, right? So once you settle down the mania, which is actually sometimes something I can do with some speed, because the SGAs are really good for settling those rageful, most disruptive states. A lot of the children are left with depression, grouchy, cranky, complainy, unmotivated, down on themselves, sometimes self-harming or suicidal. Very hard problem to treat throughout the whole life cycle. People who have schizophrenia get depressed too. And it's something that we need to recognize as its own entity, because if you just keep giving antipsychotics to that person, some of the kids will get somewhat better. They do treat depression too in some cases, but usually these are individuals who are going to need more than one medication, whether they're children or adults or adolescents. And then we have ADHD. Can you give stimulants to someone with bipolar disorder? That's a question, and the short answer is yes. We've got evidence that if the mood is stabilized and the person has ADHD, you can safely add a stimulant without destabilizing them, and will help them with all of their academic and social and even emotional regulation issues that we can help ADHD with. Anxiety is present. It's often the thing that the children are complaining about and the young people complain to me about the most. Parents are complaining about the highly disruptive behaviors and getting arrested and whatever, making scenes. But an adolescent or a child often say to me, I'm so anxious. I hate this feeling of being anxious. And And certainly, at least for even though it's not as big a part of their safety and maybe even their ability to function in the world, it's certainly very important to recognize and address for our collaboration with our young patients. And can you have mania, bipolar disorder, and autism? Yeah, you definitely can. I've got a whole set of slides about our clinic. We have an autism clinic, certain percentage of those meet criteria for bipolar. In my bipolar study, certain percentage meet criteria for autism. And the combined problem is what you would expect. You've got two bad problems, and you put them together, and each one is worse than either one alone. Together, they're worse than either one alone. Well, I think that I've shown enough slides to everybody. Would a mood stabilizer be needed if a stimulant is also used? Yeah. So one of the studies that I could have shown you is that is a large study, kind of an epidemiologic study from Sweden of 2,300 bipolar adults. And they were parsed into those with and without mood stabilizers. And then they looked to see what happened to people who got methylphenidate. And the methylphenidate treatment was tolerated in bipolar patients who were concomitantly taking mood stabilizer. And in all of the children's studies we have where stimulants are added, they do quite well, but I will tell you they're so mood stabilized, more mood stabilized than I often will see in my own clinical practice. And they use low doses of stimulants and they follow them for short periods of time. So in real life, I would say when I add a stimulant, it's like 50-50 whether it's going to help or not. Generally, if it doesn't help or there's a destabilization, taking away the offending agent allows things to settle pretty quickly. Much different than giving somebody with bipolar disorder an antidepressant. Some antidepressants can set in motion more mood cycling and mania, and they don't settle so quickly when you take those antidepressants right away. But stimulants, for the reasons I describe, I think they're like the pair of glasses kind of medicine. You take them, you see if it works. You don't give it, it's gone. So I've simplified that, but that's more or less how we think about it. ADHD is an unpleasant problem to have, to say the least. It's not because it has psychosis associated with it, but it's because smart people feel dumb and lazy, and they get yelled at all the time, and they're not living up to their potential, and they don't fulfill all their responsibilities, and they interrupt and they intrude, et cetera, et cetera, et cetera. So you can really help somebody quite a bit by treating their ADHD.
And related to that, so how would you go about pulling apart the, cognitive, like ADHD things from the cognitive symptoms of a more classic, like schizophrenia presentation?
Yeah. Well, I think one of the key things you guys will know more about it than I do with schizophrenia is that one of the key things about schizophrenia is the decline. Somebody who's at some level and then they just become much, much worse and less able to function. What we see in bipolar disorder is we see a lot of executive dysfunction, and you may see decline in terms of their ability to function, but their actual skills don't tend to decline. And for ADHD, it's the same thing. ADHD is highly comorbid with learning issues and learning disorders, along with that stimulants won't treat. You can't make somebody smarter with a stimulant. You can't take away dyslexia with a stimulant, right? You can't cure executive dysfunction is separate from ADHD, and the stimulants are not so great at treating that. But those ADHD individuals generally, what's getting in their way is not their intellect capacity. It has more to do with their tuning in and tuning out and forgetting to turn things in, and not listening to the directions, making careless errors. So it has a different quality to it.
So may I ask a couple of questions, Janet? Thank you very much for that really insightful presentation. I had a number of questions, but you answered them by going along before even I thought of asking.
Yeah.
But a couple of things, you can answer them in whatever order. First of all, if you have a kid with primary ADHD with no other problem yet,
Yeah.
is there any way to know who is the one that is more likely to develop a bipolar or a psychosis problem versus those who don't? Primary versus secondary ADHD.
Yeah,
The
good
second
question.
question is how often do you see PTSD as a comorbidity and how do you distinguish that?
Yeah, yeah. Well, let's start with the ADHD question. And that crystal ball, I wish we'd had it.
Yeah.
But we really have very little ability to predict these comorbidities. But I will say that the comorbidities for ADHD are often present at a very early age if you ask about them and can describe them and see them. So sometimes it has to be, you have to have the insight to recognize that they might have these comorbidities of depression and other stuff. We do have evidence that, like, when we use rating scales like the child behavior checklist, which is not a categorical but a dimensional scale of kind of amount of irritability, we do see that kids with ADHD who have this lower level irritability, they're more likely than not than the others to go on to develop worse problems with emotionality and bipolar disorder. Um, but the comorbidity is not something that we can address. I mean, that we know about yet. In fact, I'm part of a large study that Oregon Health Service University is doing, where we're looking for predictors of not only predictors of outcome from ADHD, but predictors of the ADHD itself in very young children. And your other
PTSD. Yeah.
Thank you. So because these kids can be hypersexual and they're rageful and all the rest and defiant, a lot of people will say to me, you're treating kids, you're calling them bipolar, but they're reacting to some type of terrible trauma that they've had. So we actually tried to study this in our clinic, and to the best that we could, and the best that we could ascertain trauma. We're not a trauma clinic. But what we found was that if you look at the ADHD kids and the bipolar kids have more trauma than the ADHD kids.
Yeah.
But when we looked at the sequencing, we saw that most of them had the bipolar symptoms before the trauma had even occurred.
I see.
So certainly trauma can exacerbate emotional dysregulation in individuals who are susceptible to that. I'm not recommending trauma to anybody, that's for sure. But it also made us realize that children with bipolar disorder are at increased risk to have traumas of a variety of types. Witnessing things that are scary, sexual and physical abuse. They're difficult kids, so they may be more prone to be harmed or disciplined by adults in harsh ways. They can be hypersexual, so they may be more kids who get exploited by nefarious adults. They may have family members with bipolar disorder who also are impulsive or not very good at supervising. So the kids fall into these different harm's way area. For girls with bipolar disorder, as they enter their adolescent years, especially, I think of them as very high risk for developing trauma because they are overestimate their capacity to take care of themselves. They start to do drugs and alcohol early, so they're intoxicated, they're in dangerous situations. And for these girls to be sexually assaulted is sadly something that I see a lot. And I try to prevent it. I try to prevent the substance abuse. You are more likely to develop a problem with substance use than your other classmates who you see who may be able to have no big deal with it. Fun, safe, no big deal. You're the type who's going to get addicted and stuck. So you need to be especially careful. And for these girls too, I try, and boys too, for that matter, I would say, I shouldn't be so gender normative about it, because the abuse can happen to anybody. But that grandiosity, the thinking that they can take care of themselves, the substance use part to hanging out with older individuals, being attracted to daredevil places and people. So a lot of times you'll see individuals who will have had this trauma like at age 13 or 14 or 15. They have tremendous emotional dysregulation. If you see them at that point and when they're 18, you're going to be like, oh my God, this person has complex PTSD. But many of them are like the kids in my clinic where they were extremely emotionally dysregulated before the trauma occurred. And that actually helped, that created a vulnerability to traumatization. Yeah. Thank you for those questions, everybody. And Kesh too. Thank you for inviting me. I was really,
Thank you. It was wonderful.
it's great to hear about your group. And I admire all the work that you're doing. And I'm easy to reach at Mass General. So if somebody comes up with a question or has some case that they want to discuss, please don't hesitate to contact me. I'm always happy to try and help.
Sure, there may be others who have been too
There,
shy to
yeah,
ask
there's
questions.
one new one in the chat. I can read it out. This is with the overlap of bipolar and autism. Do you have any information about ABA treatment and if it's useful or ineffective for children with bipolar disorder? You mentioned how parents learn about collaborative problem solving to manage these symptoms. Do you have a recommended approach that teachers and therapists can take to support the kids as well?
Yeah, for sure. Well, I'm not even sure ABA works so well for autism. There's studies now that are like, oh, it's not clear that it's the go-to for every child who has autism. And ABA is actually kind of like, it's different, quite different from collaborative problem solving, right? It's kind of identifying things in a very black and white way and trying to change behaviors. So the answer is we still recommend ABA therapy for kids with autism, and for some subset of it, it does seem to be very helpful. For the kids who have emotional dysregulation, we still recommend it, and it can be somewhat helpful, but I don't think it really gets rid of, it's frustrating because it's very much like CBT, and if somebody has untreated mood symptoms, it's going to be very hard for the therapy part to make headway. So it's often done in collaboration, right? Where you do both, give them everything we have in psychiatry and psychology. And then how about for teachers and therapists? Well, the accommodations that these kids have usually are a lot of flexibility. These are kids who are rigid and demanding, and the more flexible you can be with them, the calmer that they can be, and more likely they can participate in learning. And I guess I would say from a therapy standpoint, DBT is like a miracle that I've seen develop in my career. For borderline personality disorder, but for bipolar disorder, it's amazing. And we're bringing it down, some clinicians, to earlier and earlier ages and using it with in family systems. So DBT is like the one that I always say, go to DBT directly. As much as we possibly can do for kids, and supporting their sense of self and self-esteem. These kids feel other, they feel bad, they may look like they think they're like all that, but they usually feel quite diminished and ashamed, and that nobody loves them. Well, they sometimes invite people who stay away from them. It looks like nobody loves them because people can't get near them. So helping them understand that one of their obstacles in life is living with bipolar disorder is it's not a time-limited therapy. That's a kind of a long-term intervention.
Thank you very much, Dr. Wozniak. Really appreciate your
Thank you.
insights.
Thank you for having me. Enjoy your weekend, everybody.
Bye-bye.
Yeah,
Bye.
thanks everyone.
Thanks for help, Kelsey.